All right, good morning, everyone. I'm Eli, third year. I'm going to be giving a talk about observation. So first of all, thank you to the admin and policy team for reviewing this lecture and Dr. Youssef for helping mentor me through this process. So today I'm going to talk about what observation is, a little bit of the history of observation units, the billing that is behind observation and why essentially it's important, the different types of observation units, some patient-centered outcomes, metrics that are being looked at, and then we're going to finish with a quick overview of our observation. So first of all, what is observation unit? This is defined by Medicare as essentially services that include a bed, periodic monitoring, and it's reasonable and necessary to evaluate a patient's condition to determine whether they need admission, whether they can be safely discharged home. So just kind of breaking this down, it's essentially for patients who may not require a full hospital admission, but can't yet be discharged. Do you want patients to stay for under 48 hours? And we'll talk about why. It's determining the need for a full admission to the hospital, and essentially it's described as a third option for emergency. I think good examples of this are diagnostic uncertainty and also determining whether a disease process is going to progress or get better. So for example, our chest pain patients that had negative initial troponins, but were worried about ACS, the diagnostic uncertainty, where observation can be used to determine if the troponin trends up, or they have a positive CAP or EKG changes or something else that would determine an inpatient stay. An example of a disease process that might get worse or better would be cellulitis, a patient that requires maybe one dose of IV antibiotics, and then determining if they develop fever or systemic symptoms or spreading of the cellulitis would be a reason, again, for inpatient. So a quick history lesson. The observation unit, EDOUs, have really been around since the development of the emergency department. I think emergency providers have always liked this third option as a way to help guide disposition. This increased in 2007, but it really is stemming from Medicare's payment system change, which was in the 80s, the inpatient prospective payment system, which I'll talk about in a few slides. But at that time, the average length of stay of an inpatient hospitalization was around 10 days. And due to essentially incentivizing a decreased length of stay of hospitalizations, it then decreased by about half to 5.1. And today, as most of our IM colleagues can tell us, a lot of people stay less than 2 days in the hospital and they're discharged very, very quickly. In 2007, the observation actually extended. So this is all, again, based on billing in a way, but in 2007, the pay for observation status was vastly increased. So we vastly increased the things that we can put on observation. In 2015, CMS develops the 2 midnight rule. And essentially what this is it's a metric that RACs, or audit contractors, which look back at billing for appropriate hospital stay, use to determine a check mark if patients meet the criteria for inpatient. So a patient has to stay for over 2 midnights to make this checkbox for essentially appropriate billing for inpatients. That can either be 24 hours and 1 minute if you're discharged from the ED at like 11:59, or it can be 48 hours if they're discharged in this is not all-encompassing. So if patients leave AMA, or they die, or they're transferred, this 2-minute rule is not necessarily counted against the hospital, but it does help the auditors look at this. The other thing that people look at is utilization management. So this is where Milliman comes in. The other one is McKesson Interqual, which we don't really use here. But utilization management is essentially agreed upon by evidence-based experts, Medicare and private insurances to determine if patients meet the appropriate standards for inpatient. It's billing. It helps people know, is this an appropriate thing that we should bill? And this is why sometimes, even when patients stay for under 48 hours, it's still an appropriate hospital. I think a good example is at downstate when we do CCU, we see patients with positive troponins that are capped, that are negative, they're downtrending, and they're still discharged within 48 hours. But because they meet the criteria for utilization management, they are still paid as an inpatient hospital. And really what this comes down to is the inpatient perspective payment system versus the outpatient payment system. Outpatient care is encompassed in both the ED and the observation status. So all of these patients are counted as outpatients in the purposes of billing. Why that matters is that inpatient hospital stays are essentially bundled under DRGs, or diagnosis-related groups, which cause a decrease in the overall pay with an increase in the overall cost for a hospital admission. Outpatients, ED and observation, are billed on a more fee-for-service model. So you bill for each individual thing. So, for example, at downstate, we code for our EKGs that we read and our chest X-rays that we read, versus an inpatient stay is all billed into one specific thing that's paid per day. Some things to note: that observation really can only be billed over 8 hours. Once the stay in observation is over 8 hours, because you get another code added onto your chart, and then you can bill for outpatients. Stays do have some negative outcomes on patient payment as well. So patients are paid under Medicare Part B for this, which means that they're actually responsible for 20% of the copayment and for 100% of any medications they could otherwise be taking at home. So when we're in our observation and we're doing these things, patients may incur slightly more costs than if they were fully admitted to the hospital. But for most patients, that doesn't actually end up being. The other thing to keep in mind is that patients that require placement in long-term facilities, there's a rule that they need to be in an inpatient hospital stay for 3 midnights to be placed in a skilled nursing facility, and the observation status does not count towards those days. The other reason, just in terms of billing, why observation is useful is that when hospitals admit patients, they are readmitted within a certain time frame. The hospital loses money. They get dinged for a readmission, and the observation stay is not an admission. Remember, they still get counted as an outpatient. So we don't do this here, but some places do CHF exacerbations for observation stay. If someone is placed in observation for a CHF exacerbation and then comes back and gets admitted, that's not a readmission. That's a repeat hospital visit, but not 2 admissions to the hospital. This is a slightly old chart, but one that I think is very useful. It's from around 2010, determining the different costs of an inpatient versus an observation unit stay. So across the board, you can see for these common observation type diagnoses that inpatient stay just costs more. There's more care team members, patients generally stay longer, and you actually need more space as an inpatient. So the costs incurred to the hospital are higher for inpatient versus observation unit stays. ASAP has a policy statement on observation units, which is really essentially a strongly worded letter. But this is essentially saying that observation units should be run by the emergency, that we should be in charge of making policies and procedures, that we should be the ones kind of making these decisions. And this is part of the reason why you saw our observation unit at county change from internal medicine over to emergency medicine units in accordance with this policy statement. There are 4 types of observation units. This is coined by Ross, kind of in the landmark papers around observation, types 1 through 4. Type 1 is a single place in the hospital, like we have, and all protocols are. Type 2 is a little bit of discretionary care, so there are some protocols, but there are also people that are admitted outside of protocols. And usually it's a variety of specialists, but it still is a unit in the emergency department or near the emergency. Type 3 is protocol-driven, but not location-dependent. They're admitted anywhere in the hospital in any unit. And then type 4 is discretionary care, so not protocol-driven, and it is in any place in the hospital. And type 4 tends to be the most common because it is the lowest cost associated with the startup of observation. Type 1 has the most level of evidence, although to be fair, the evidence is not particularly great. Then you can also kind of categorize it as open versus closed. So open unit means that anybody can admit versus closed is only a certain specialist can admit. A hybrid unit, which is boarders and patients that are scheduled for a procedure and observation, and then a pure, which is one specialty and no planned procedures. So at county, we really have a type 2 open hybrid unit based on these definitions, because we have patients that are placed for procedures, we have patients that can be admitted under some specialty units, and then we have our more protocol-driven emergency 8 beds as well. At county, or excuse me, at downstate, it's really a type 4. When you admit patients, you can admit to anywhere in the hospital under OBS or admission. Yes. So just in terms of some outcomes, in terms of chest pain, AFib, TIA, and CHF, which are the most studied for observation, all of these have better patient satisfaction scores for observation stays versus inpatient stays. They have obviously decreased amount of time in the hospital, and they have decreased costs occurred for both patients and for the hospital based on the data that's been written about, I should say. And then in terms of patient safety, which I think is important for us to think about as well, when patients stay out of the hospital for longer, they're less likely to get hospital-acquired problems. Medication errors, pneumonia, catheter-associated infections are all things that happen as patients stay longer and longer times in the hospital. So observations can help decrease these bad outcomes for patients as well. There was a paper written in 2017, and a combination of both American and UK emergency doctors. I think that these quotes actually encompass very well the thought process behind observation. So observation as a medical purgatory. The current policy is Madden, designed to confuse and enrage physicians. It's a safe space for dealing with patients who fall outside clean diagnostic categories. Without explicit diagnoses and intended courses of care, they become clinical in decision units. We sometimes need longer with these patients to see which way their disease is progressing, and it gives us a third way to keep patients safe. And then it's clinical decision-making influenced by financial incentives. I think across this board, it's an acknowledgement that observation unit is a potential useful option for emergency providers in terms of a disposition that's not admission or discharge, but it is kind of driven by these larger themes in medicine that are related around money. It can be very frustrating to determine if the protocol is appropriate for a patient for observation versus admission. There's a lot of gray area that causes a lot of confusion, a lot of rage around observation, which I think we have all seen. There are metrics that are used on a national basis to determine if this is a highly functioning observation unit. So it's patients per bed per day. And generally, you want this to be above 0.9 for your beds. Length of stay, which should on average be 15 hours. Successive discharge within 48 hours, and then percentage of admitted patients from observation. You generally want 70 to 80% of your observation unit patients to be discharged from observation and 20 to 30 to be admitted. You essentially want to encompass as large of a group of people as possible on observation without discharging too many people from the ED or accepting too many people that then get upgraded to observation. And just going back to billing for a second, the reason why that matters is because when patients stay for more than 48 hours, their payments become bundled into that DRG. So you end up losing money for the observation status instead of making, right, saving money for the under 48-hour care with the extra code. I just wanted to end with a quick overview of our observation units. Most of us have had some experience with this, either admitting or working in object at this point. So we do have some protocols that were created for specific diagnoses. This is an overview of them. We are trying to expand these protocols, and we have been accepting patients that aren't necessarily perfectly fit within these protocols as well. Again, a nod to that type 2 unit we're currently running. We do have subspecialties. So currently trauma is the only bed or only people that have submitted protocols to be used. But there are other subspecialties that potentially can stay. You can either admit under the observation unit protocol, the thought would be the under for 2 midnights, or some specialties can admit under their own protocols as well. And then we are looking at metrics in our observation unit as well, very much in alignment with the national metrics that have been created. So in terms of volume, how many patients do we have? In terms of revenue, are we making? Are we losing money? Is this observation unit actually successful? How many patients are actually admitted versus discharged? And then obviously patient safety and utilization management as well. So just some takeaways. Observation units are financially driven by changes in Medicare reimbursement, utilization management, and private insurance companies. They do have some patient-centered outcomes, but it can be seen as a financial process. And then observation can be very frustrating, but it also is a nice third option for us as EM providers to help us in our disposition decisions. These are my resources. Any questions? Yes.
Comment. Excellent. Very well covered, Eli. Thank you. Years ago, this was not embraced by the emergency medicine community. Just thought it was extra work. No, why should we do this? It's very nice to see, as I've been saying for years, that we need to do this. Is an opportunity. We do it better than anybody, more efficiently, and it's better for the patients, and obviously it's better for the bottom. Excellent.
Thank you. Teresa?
So, excellent presentation, Eli. Very difficult to take sometimes dry topics and turn. The one thing, this is more for the seniors, if you enter a practice in the next few years, you'll see a lot of the smaller community shops that have, I guess, much better efficiency because of the amount of volume there. They will actually ask you to place a patient on observation under yourself. Meaning, if a patient's going to obtain a CAT scan of the abdomen and pelvis, they'll say, put them on observation under yourself. This actually has reimbursement on the hospital side and a little bit more on the RVU professional side as well. Just some things to be aware of as you enter the different kinds of practice. Great job.
I also want to piggyback. That was so well. I also have to piggyback on what he just said. We're embracing that initially about the emergency room community, and you can see the why, right? Because we see kickback even now, people scratching their heads because observation makes the clinician actually think of the financial aspect of their care. That's what it does. And that is kind of a struggle for us as doctors to switch from the clinical brain to the financial brain. The goal for the unit in 2021 is you mentioned the team players, the stakeholders for observation. Yes, there's the clinician, that's the leadership part of it. Nursing, is huge, okay, because it's financially driven. So with the hospital leadership across the street, they have buy-in to this. To have the team in real time, and this is what the vision is for 2021, to help you make these decisions, okay? To prep you so that when they see the patients going down the ACS rule-out route, they say, this is a person that's been here yesterday. I know you might think that you want to admit them upstairs, but we're not going to get reimbursed. Let's just put them in ops to assist you. And then you can have a conversation. They're not making the final decision, but they're the conductor. The places that I've worked in, the two institutions prior to this, I was used to that type of setup, and it really allowed the physicians to embrace this culture change. Because what he's mentioning, the reason why we was first, it was like, this is extra work, right? It's a different culture change, and for Kings County, it's a huge culture change. But very well done. The other last little piece is the Moon document. This is a document, you mentioned payment. We know about it, but the patients need to know about it. So it is by law important that the registration clerks tell the patients, listen, this is not a full admission, because they can always refuse the admission, paying the bill at the end of the day if they say we never were to disclose this. It's actually a document that's given to the patient, MOON. Okay, and we're working on that because we looked at the compliance of that, and it's very low across the street. That has to do with buy-in from other players, but very well done.
Yeah, very well done. Just want to comment. I remember when the observation unit started, it was kind of a hybrid between medicine and us supplying the residents. And I could see at that time, to be honest, that the residents were a little resentful having to do it. They felt it was extra work and we were doing it via extra line. But more and more, and now that we've taken over the OBS unit, it's a good experience. It's a great experience, I think, for residents. And when you go out there, you can say, I as an attending, and especially in this environment, in this economic environment now, hey, I have this skill and I'm willing to do this. In fact, one of our grads, Bonnie Brown, is actually the head of the OBS unit for both Mount Sinai West hospitals, Morningside and the Mount Sinai West of Roosevelt. It's a good opportunity and something you can feel confident with. And working in fast track, I like it because I have patients, you know, who it gives me that third option. They have an infection. I don't know which way they're going to go. They're not that sick. It's very nice for patients, and I think it's good for you guys to train in it. I really do.
Any questions from the residents about the future of it going on?